Hey everybody, happy Thursday. We are almost to the weekend and it is time to drive in five. So let me go ahead and get up what I have going for you today. We have been talking about cardiac stuff this week because remember, week by week, we're chipping away at all the foundational pieces that you guys are going to build upon as you continue learning and then eventually, become a CRNA and begin your own doing it. So today I wanted to quickly talk about pre-oping the cardiac patient who is undergoing elective non-cardiac surgery. Okay, so that's what we're going to touch on today. So overall, you guys, I want you guys to remember what your job is. Your job is, can this patient safely undergo surgery? That's your job. Is this patient going to be safe? Are they optimized for surgery? And then how can you, as the anesthesia provider, mitigate any type of risk factors and any type of cardiac complications, okay? So that is the job. Now, for emergency surgery, that's a different beast. A lot of times you have to do it, and your job is just to pray to God the patient is okay and mitigate the risk factors. But overall, you're going to see a patient on the floor for a procedure. You have a patient coming into pre-op. Is this patient optimized and able to safely undergo their gallbladder or whatever the heck it may be, okay? Now, these are all the parts that you're going to be thinking about when you are looking at your cardiac patient. So first of all, what diagnoses? What is a cardiac, patient coming in? Patients that have CHF, any type of dysrhythmias like AFib, any type of valve disorders, pacemakers, ICDs. Have they had a previous MI? Have they had a CABG before? Have they had cardiac angioplasties? Do they have stents in place? Those are all the things that you are going to be like, okay, we are going to need some type of cardiac clearance for this patient. Now, the other thing that you want to think about, what is any concomitant diseases that go along with this cardiac patient? So things that are going to increase their risk factors for surgery and having some type of potential complication post-op or intra-op. Do they smoke? Are they on drugs? Are they a diabetic? Think about the vasculature of diabetic patients. Have they had a stroke in the past? Have they have some type of TIA? That's also alerting you there's some type of issue. Do they have any sort of renal disease? Are they on dialysis? Are they maybe just in CKD stage 2 or 3? Do they have PVD? Do they have PAD? Stuff like that. So you're constantly looking at all those things. Okay, that's going to up my risk factors. Now, what is the surgery? The highest risk surgeries for any type of complications, especially in cardiac patients, are intraperitoneal. So are you in the belly? Are you in the lungs? And are you doing any type of vascular procedures? That's also going to increase and heighten your brain. Like, okay, we really need to mitigate some risk factors to keep this patient safe while they undergo this procedure. Now, I started timing in here because I'm not going to go through all the timing things because it's a lot, but you always want to be thinking about timing. So if the patient had an MI or they had a CABG, when was it? 6 months ago, a year ago, 2 weeks ago? Because that matters. Now, if the patient has any type of AFib or any type of clotting issue or anything like that, are they on blood thinners? When have they been off their blood thinners? Has it been a week? Has it been 2 weeks? Has it been 2 to 3 days, depending on, whether it's Eliquis, Plavix, aspirin, etc. Are they able to be off those drugs? Have they seen their cardiologist recently? And that's part of the workup process, okay? So you're always going to be thinking of timing of these things as well, okay? So what does the workup entail? Do they have a recent EKG? What does it look like? Has it changed from maybe the one they had a year ago? Have they had a recent stress test? What did the stress test show? Any signs of ischemia? If they have a pacemaker, AICD, has it been interrogated within the last 6 months or so? Do they have a recent echo you can look at? What is their EF? Pay attention to their labs. What's their H&H? They have renal disease. Are they anemic? Do we need to correct that? What is their renal function? Has it gotten worse than maybe some previous labs? What are their coags? What are their potassium, their sodium, their electrolytes, right? So you're looking at all those things pre-op. What are their vital signs? You can usually get your vital signs preoperatively, but you also can look at maybe vitals from a note when they saw their cardiologist, their neurologist, whoever. What's their heart rate? What's their blood pressure? What are they usually at? We want to keep them within that baseline, right? As I said before, have they seen their cardiologist? And one thing to think about is platelets. So they might have a decent platelet counts, but are those platelets functional depending on what medications they're on, okay? Like I said before, do they have cardiologist blessing to stop their blood thinners, okay? Are they on beta blockers, ARBs, ACE inhibitors, calcium channel blockers, diuretics, antiarrhythmics? For the most part, we want them to take their cardiac medications pre-op, but there are some instances where we might not, okay? So looking at all those factors as far as medications and as far as of your workup and looking at the timing of everything. And then super, super important is what's their functional status, right? Sometimes your patients look like a train wreck. I'm like, oh my God, this patient is a disaster. And then you go see them and they're like, yeah, I quit smoking, I eat vegetables, and I go on a walk every single night. Okay, so what is their functional status? Do they grocery shop on their own? Can they make it around a grocery store? Can they make it around their kitchen? Can they do light housework? Can they clean? Can they get up a flight of stairs? Do you have to go into stairs to get to your house? You do that every single day, or your apartment? Can they walk a block? Stuff like that. So that is super, super crucial to their functional status. Any recent chest pain in the last few weeks? When do you get short of breath? How far can you go before you get short of breath? Do you stand up and sit down and you can't breathe, right? All the things you're going to be thinking of as you're putting together this picture, okay? Oopsies. Okay, there we go. And then what is going to be your to-do list, right? So you get this patient, you feel like they're pretty optimized, they're good, or maybe you have an emergency patient. What are all the things that you can control, that you can work with? Number one, beta blockers. Beta blockers really show to help decrease the risk of perioperative MI, right? You might need to give them a little bit. You might want to think about emergence. You don't want a really ugly emergence where they're spiking their heart rate and their blood pressure up and you're putting demand on that heart. So sometimes I'll titrate some beta blockers in as I'm waking them up, to kind of keep that sympathetic response at bay. Start low, drop it low, and go slow, right? So everything, patients that have vascular disease, diabetics, etc., cardiac patients, they can be super sensitive to medications like glycopyrrolate could totally jack up their heart rate. Give a lower dose. Ephedrine, phenylephrine, they might have an exaggerated response. You might give them 100 of Neo and their blood pressure is 209 over 101 now. And I'm like, oh my God. Okay, so dose very carefully. Get to know that patient under anesthesia, right? Decrease their anxiety, keep that anxiety down, be super vigilant, okay? That's your job, right? That's the number one job. Be watching. What is their baseline? What does this patient look like? How are they looking under anesthesia? How do they look post-op, okay? Keep them normovolemic, and obviously you wanna correct any type of anemia and electrolyte imbalances, okay? That is all I have for you. I know that was a lot of information. If you have questions, please ask me. That is what I am here for. And remember, most perioperative MIs occur within the first 24 to 48 hours after surgery, okay? So be aware. If, when you're post-oping these patients, ask questions, look us up. I actually saw a patient that had a perioperative stroke and couldn't move his arm the next day and nobody had picked up on it, okay? So be vigilant when you're doing your post-ops, okay? All right, you guys are awesome. I am cheering you guys on. Get these cardiac assessments going because they're super, super important, and they're going to make you a super awesome CRNA, and they're going to make you look amazing in front of your preceptors, which is the goal. Okay? You guys have an awesome day. Love you guys. Bye.